Gusto und das Dreck.
Okay, round 2 of 3. So this is optic neuritis. This is a scenario that everybody's going to face, and it's an evolving situation because with the knowledge about neuromyelitis optica and recognizing this disorder more often and trying to decide what to do when you see a patient with optic neuritis, it's becoming more complicated. This used to be a fairly simple lecture, and it's gotten to be a lot more complicated because you have decisions to make now that you didn't really have to make before. So we'll go through that a bit and try and sort that out somewhat. So you can call these different things. You can call MS related, or some people call it demyelinating. There are other sorts of labels for MS that's related or optic neuritis that's related to MS, or all the other ones, NMO, infectious. The others we call atypical. That's one categorization. There are different ways to talk about this, but for this lecture, that's the way this is going to go. So here are the kind of different scenarios that you might think about for optic neuritis. A 35-year-old woman who's got a week of visual loss in the right eye, pain with eye movement, decreased acuity and central scotoma there with a relative afferent pupillary defect, a little bit of disc edema, and if you did an MRI, it would show this kind of a pattern. Enhancement of the optic nerve, not particularly dense white, not particularly large, but a little bit of enlargement and some enhancement of the nerve. So that's one scenario. Here's another scenario for optic neuritis. 7 days of visual loss, right eye, no pain. Visual acuity down to 2200, a relative afferent pupillary defect, and a disc that looks like this. All kinds of disc edema, hemorrhages, macular exudates as shown here, and the MRI is normal with the intraorbital and intracranial optic nerve. Or this, 35-year-old woman, 2 weeks of visual loss in the right eye, pain with eye movement, and subsequently develops visual loss in the other eye as well. So both eyes are involved, finger counting vision in both, pupils are sluggish. The nerves, in this case, look normal. They might be swollen. They look normal. And the MRI shows this, bilateral bright enhancement of both optic nerves in long segments. So 3 different clinical scenarios for optic nerve inflammation. And you have to be able to kind of think about those and sort them out. One of them, the first one, was the MS-related optic neuritis. The second one was an infectious optic neuritis. And the third one was neuromyelitis optica. So we'll talk about those individually here. So the first is the part that used to be the simple part of this optic neuritis lecture. A young person, more commonly a woman than a man, pain with eye movement in most of the cases. So a lot of these percentages I'm going to give you are from the US optic neuritis treatment trial, where we have a lot of data on this for this type of optic neuritis. So pain is really common, and if you don't have pain, you might start thinking that it's not optic neuritis, or it's some other kind of optic neuritis other than MS related. So the visual loss happens over days. It's not, I woke up with this one morning and it was out like a central retinal artery occlusion. It kind of creeps up over days and often has the pain preceding the loss of vision. And there's a relative afferent pupillary defect if it's asymmetric. Patterns of visual field loss for optic neuritis. So you kind of think about in the textbooks that it should be a central scotoma. This kind of central scotoma is not that common, actually, for optic neuritis. In that trial, this sort of thing was less than 10% of the patients that came in. And interestingly, this, which you think about for ischemic optic neuropathy, was actually almost twice as common as this, about 15%. Most of them were generalized depression within the central 30 degrees. So it's still a central scotoma, it's just a big central scotoma. If you looked at the rest of the field outside of this on Goldman perimetry, that was relatively spared. But a larger depression of visual field is more common than this thing, which you might intuitively think about for optic neuritis. And as I showed you earlier, this is the classic pattern for this type of optic neuritis. And if you do this kind of scan with thin sections through the orbits, fat suppression technique, and gadolinium administration, you'll see something like this in 95% of the cases. So usually you don't need this to make the diagnosis, but in some sort of weird cases of optic nerve disease, you might need this scan. And if you don't see it there, you should start thinking of other possibilities for that, because it's almost always there. So what happens with this type of optic neuritis? Well, usually the pain will resolve over days to weeks. Vision starts to recover within a few weeks usually, and it's going to recover to where it's going to end up within a month or two. And the visual outcome is usually quite good. So in the neuritis treatment trial at 10 years, over about 75% were at least 20/20 vision, bad vision in only 3%. And even the cases that showed up with no light perception at the start, over half of those were better than 20/40 at the end. So the general prognosis for this is good. This is a reminder that not all of them get better. So don't tell your patient 100% your optic neuritis is going to go away, your vision is going to come back, because there's a small percentage, even though most of them will get better, some of them are not going to get better. So you don't want to give them a false assurance that everybody gets better from this. And then the thing that everybody wants to know about, just like with ischemic optic neuropathy, the patients want to know, what's the chance this is going to happen again? So it's about a third, over 15 years, we'll have a second event in one eye or the other eye. So that's about the number that we usually use for recurrence of optic neuritis, untreated. The other thing that everybody wants to know, what's my risk of multiple sclerosis after I've had a single episode of optic neuritis, and this is the 15-year data from the optic neuritis treatment trial. Overall, all comers, no matter what your scan showed, about 50% are going to have some degree of clinically definite optic neuritis at 15 years. If your MRI is totally clean, no lesions at all, it's still 25%. So even though the MRI is totally normal, you're not out of the woods for this. If you have at least one lesion that looks like an MS lesion, oblong-shaped around the periventricular region of the brain, this is a T2, but FLAIR images are even better for looking at this. One spot goes up to 72%. So very high risk that you're going to have clinical MS at 15 years after the onset. So what do? Should everybody get an MRI? You want to assess for the risk of MS. In the US, we recommend that everybody gets an MRI. Should you use steroids for optic neuritis? Will it improve the visual outcome? Will it reduce the risk of MS? Should you use MS therapy for patients that you haven't really confirmed that they have MS yet? They just had optic neuritis. So let's look at that for a minute. Again, the optic neuritis treatment trial, very well known. The results for the US anyway was that we don't use oral prednisone alone at the standard milligram per kilogram per day dose, because it didn't have a visual benefit, but it also increased the recurrence rate in this study by 2. That's a controversial finding. The neurologists who look at this often don't believe that that's a real finding, but at least in the US, we talk about not using this dose of oral prednisone for this type of optic neuritis because the recurrence rate was doubled in this study. It's not the oral route, it's the dose. So if you can get an equivalent dose to a gram of methylprednisolone per day given orally in dexamethasone or some other way, you won't have that issue with the recurrence rate. And it's hard to give that much in the form of pills. In the Philippines, where I trained a couple of fellows, they don't have the intravenous available. They crush up the pills in a smoothie and give it to patients that way. And it's just as good as the intravenous dose. The intravenous dose, a gram a day, you can do that for 3 days, you can do it for 5 days. Some people use a taper of oral steroids after, some just give the intravenous. Speeds recovery. So if you're seeing the patient within the first couple of weeks and they have a need to get better faster, it's a pilot, they might have bilateral visual loss, they have some other need to get better quicker, this will speed the recovery at least by a few weeks, and so we do occasionally use it for that reason. It still has no long-term benefit. So the oral steroids, whatever dose, The intravenous dose does not have a long-term visual benefit for this kind of optic neuritis. There was some interesting data early on in the optic neuritis treatment trial looking at whether you would progress to MS based on whether you got the oral corticosteroids. And at 2 years, there was a decrease in conversion to clinical MS, but it did not go out after 2 years. The placebo patients sort of caught up with the others. So a single dose of the intravenous, single over a few days, doesn't reduce the risk of MS long term. But we don't know whether if you kept pulsing every couple of years, you might reduce the risk of going on to MS. And there are some data that suggests that pulsing steroids might be beneficial. It hasn't really been clearly tested for this. But assuming the steroids don't work, is there something else you can do to lower the risk of going on to MS if you've got an abnormal MRI? So that's the CHAMPS study. This is now almost 2 decades ago. It was a study looking at if you had a single demyelinating event, clinically isolated syndrome, and half of the patients in this study had optic neuritis. So it was a good study looking at whether you could do something about patients who had optic neuritis about going on to MS. In their study, they had to have an abnormality of 2 lesions on the MRI. So optic neuritis patients, abnormal MRI, high risk for MS, they all got steroids. So all the patients in this study got steroids, and then they were randomized to either getting interferon beta, Avonex, this was an industry-sponsored trial, versus placebo within 3-4 weeks of onset of symptoms. And it was planned to follow them for 3 years and see what compare the conversion to MS in treated versus placebo. The study was terminated after the first interim analysis because no matter how you looked at the data, there was a significant drop in the rate of conversion to MS in the patients who got the Avonex. This was followed by the so-called Champions study, which was analyzing whether the patients who got the treatment early did better than the patients who got the treatment later. And they did, actually. So the earlier treatment also reduced the risk of going on to clinically definite MS. And so that was further evidence that this medication reduced the risk for going on to MS. And since then, there have been lots of clinical trials looking at pretty much all of the platform drugs in multiple sclerosis, the risk of going on after a case of optic neuritis or another clinically isolated syndrome. They all reduce the risk. So everybody gets it, right? I'm not sure that everybody gets it, and this is still a discussion point. It's very expensive, number one. Some of them, there are side effects for all of these drugs, and you are basically committing these patients to immunomodulation for lifetime at this point. And these are patients who may have had 1 episode of optic neuritis, and that's it. And that's a discussion that really needs to be made with them. 25% of these patients, particularly the ones with clean scans, are not going to go on to MS at 15 years, and you've put them on immune modulation agents possibly. So it's a discussion point. And generally speaking, if I have a patient in this scenario, if the MRI is totally clean, I'll generally talk to them about it, but I won't send them further because the risk is low enough that we don't really know that the drugs make a difference. If they've got an abnormal MRI, usually I will send them to neurology for the discussion about whether they're going to use this medication. And the neurologist may put them on right away, or they may say, I want to wait 6 months, do another MRI scan to see if you have new lesions. And if you have new lesions, we know this is active, and then we would treat at that point. There is some evidence, as I said, that using steroids in every case might be beneficial. Pulsing steroids to prevent activity later on, reducing. But the other issue that's come up now, and we'll talk about this toward the end of this talk, is that you don't know whether this case of optic neuritis is going to be an NMO case when you first see it. They may look similar at the start. And if you delay the onset of steroids and it turns out to be neuromyelitis optica, you've delayed the treatment. You may have doomed them to have ineffective treatment. So you've got to think about that issue as well, and we'll talk about that. Okay, so we've done that. What about the other end of the spectrum? So atypical, so-called atypical optic neuritis. There are some things that you should see on your initial presentation that point you away from this demyelinating MS-related optic neuritis to something else. One of them is lack of pain. So a patient comes in with an optic neuritis picture. They have no pain. You should at least be thinking about the fact that it may be a different type of optic nerve inflammation. Atypical demographic, older man, for example, who's got this, not the typical young woman who comes in with it. An atypical clinical course. So instead of loss of vision over a few days to a week, this is slowly progressive over 2 months. It doesn't go away. The pain doesn't go away. The edema that's in the disc doesn't go away in 3 to 4 weeks. That's unusual for MS-type optic neuritis. Or it's steroid dependent. You give them steroids at the start, vision gets better. As you're tapering off the steroids, vision goes bad again. That's not the way that MS optic neuritis usually works either. Severe loss of vision. That can happen in MS-related optic neuritis, but it's not typical. Light perception, no light perception vision. Bilateral simultaneous onset, not typical for MS, although all of these can happen, but they're much less common with MS. This kind of a picture, basically never multiple sclerosis. So optic nerve inflammation that produces this, it's something else. And if you've got an associated uveitis, MS can produce a uveitis associated with the optic neuritis, but if it's a prominent uveitis, you should be thinking about some of the other things that we'll talk about here in a minute. So again, looking at this kind of picture, this was the neuroretinitis picture that I showed you earlier. Swollen optic nerve, but in addition to the swelling, which is pronounced here, flame hemorrhages, and this huge amount of, in this case, macular exudate. There may be vitritis as well, maybe paraphlebitis in the periphery, which can be an MS, but depends on what the paraphlebitis looks like. It's not typical MS-related optic neuritis. And the way that it looks on MRI imaging also makes a difference. So, as I mentioned earlier, more intense contrast enhancement. If the sheath is more involved than the nerve itself, it may point to something else like an optic nerve perineuritis, a different cause for that inflammation. Or if the adjacent orbit is involved with inflammatory tissue, that might be orbital inflammatory disease rather than optic neuritis. So, optic neuritis that looks like this, probably not MS, or this, very bright, very enlarged. This one actually has sort of a nodular or kinked appearance. That's very unlikely to be MS related, and you should start thinking about whether that's something else, and this is a sarcoid in this scenario. If they've got a systemic illness, they got they had a viral illness, either during the optic neuritis or during a couple of weeks before the optic neuritis, bilateral onset as well. You might think this is a post-viral or viral-related optic neuritis rather than MS. If they're immunocompromised, if they have autoimmune disease, lupus, for example, different ballpark. So these categories, we usually think about either infectious causes or non-infectious inflammation. And the infectious causes, the two that we really think about in the US commonly are Bartonella and syphilis. Syphilis is still an issue. I'll show you a quick example of that as you go along. There are others in there, but infections can produce it. Neuroretinitis, this Bartonella thing, is the most common. Another example of this disc edema, flame hemorrhages with macular star exudates. One caveat is, if you see a patient like this, and particularly if both eyes look like this, that might be Bartonella infection, but you got to check their blood pressure in this scenario, because malignant hypertension can look exactly like this. Usually it'll be both eyes, but you got to keep that in the back of your mind when you see this. So this is so-called cat scratch fever, and most of the patients are not going to tell you that my cat scratched me 2 weeks before I developed visual loss. So if you have this kind of a picture, you need to ask about it. But cats, some other pet, other than cats, can produce this kind of infection. They may or may not show the fever and the rest of the systemic illness. The loss of vision in these cases tends to be out of proportion to the amount of optic nerve disease, because a lot of the loss of vision in these cases is the macula. They've got all this exudate in the macula. So you may have a 2400 or count fingers lesion and only a minor relative afferent pupillary defect because of that. And if you did fluorescein angiography on the macula, it's not cystoid macular, it's exudate there. So there is serology available for this. If you suspect it, if you see a neuroretinitis picture, we're usually going to order that in addition to syphilis serology maybe toxo, TB, and Lyme, depending on the clinical scenario. But most of these cases, even though they look terrible at the start, they're going to end up doing pretty well. Once the macular exudate goes away, their vision tends to come back. The optic nerve damage is usually relatively mild, and so the prognosis is typically pretty good, even though it's a really bad-looking fundus appearance at the start. That kind of a clinical picture and Bartonella infection sort of picture, never MS, really. You don't even think about whether there's going to be multiple sclerosis related. Typically, I would not order an MRI in a neuroretinitis picture like that. Almost always it's going to be negative. The part of the optic nerve that's involved is just at the disc. It's not in the orbit or in the brain. And treatment of Bartonella infections for us is still optional. It's a self-limited disease for the most part. The really bad cases, or the cases that have systemic illness at the time, we will send them to infectious disease specialists and ask them what they treat with, because it's all over the place what they treat with. Every week it's a new disorder, a new drug for the treatment of Bartonella, because we don't really know what the best drug is. But the other point is steroids don't work for this. So we don't use steroids for that kind of a picture. We don't think about MS. But what about other infections, bacterial infections? And I mentioned that syphilis is one that we still think about. The kind of optic neuritis that you get for these kind of infections can be anything. It can be the typical appearance, it can be an atypical appearance, it can be anterior with disc edema, it can be posterior, it can be acute or chronic, it can be isolated or with a systemic syndrome. And the diagnosis of this stuff is made by high index of suspicion. So the things that start out that don't sound like the MS kind of optic neuritis. So you need to ask about it, you need to ask about systemic symptoms, and you need to look for other things. Look for skin lesions that look like syphilis. Look for associated intraocular inflammatory disease. Do the testing if you're concerned about this. Let me show you this one case from UCLA here recently. This was from about 2 years ago now. 54-year-old man who had ischemic optic neuropathy. This was the confusing part. He'd had ischemic optic neuropathy in this eye, I think a couple of years before. And he had an atrophic nerve with an altitudinal field loss. Then he developed the vague onset of painless superior visual field loss in the left eye. So he started to get this stuff. And he wasn't really clear when it started. So it wasn't an acute event like NAIOM when you know when it happens. It was sort of slowly, vaguely onset progression. Didn't have any new systemic symptoms. At that point, he had 2100 vision in his old atrophic eye, and this eye was swollen, but it was still 20/25 vision. He still had a relative afferent pupillary defect in this eye, but he had this markedly swollen optic nerve. And did fluorescein angiography because he had a high sedimentation rate and a high C-reactive protein. There was some question about maybe he was a young guy who had giant cell arteritis. And so he eventually went on to the temporal artery biopsy that was negative. But interestingly, his fluorescein angiography looked like it might be this ischemic optic neuropathy that I told you about yesterday, because he'd had it in the other eye before. And it filled really poorly. And then it leaked late, which is what ischemic optic neuropathy looks like. The thing that was confusing here is that this actually was blockage. This is so black here. It's not a non-filling disc. It's a disc where the fluorescein is blocked by a dense infiltrative thing within the nerve. He developed some additional retinal problems in this eye, and then we started thinking that he might have intraocular lymphoma because his vitreous became hazy. He developed more retinal infiltrative processes. So we took him to the OR, the operating room, to do a vitreous biopsy. And in the workup for surgery, he was found to have an arrhythmia. And then on echocardiography, he was found to have cardiac vegetations. And so infectious disease was called to see him in the pre-op area for him to go in for a vitrectomy. They noticed, and nobody else had noticed this in the 2 weeks, 3 weeks of examining him over and over again, that he had some rashes on his abdomen, on his hands, and on his feet. So eventually they did the syphilis serology, and it turned out to be a syphilis optic nerve inflammatory disease. So even in this day and age, none of the ophthalmologists saw this. It took a real doctor to be able to see this. So they saw that. If you see this kind of a thing, of course, intraocular or optic neuritis due to syphilis is CNS syphilis. So that needs to be tested in that way, infectious disease, lumbar puncture to see what the CNS looks like, and the intravenous therapy for syphilis in this scenario. Here's a second case of atypical optic neuritis. 36-year-old African-American woman who's had 3 weeks of progressively decreasing vision in the right eye. Pain, not so much pain with eye movement, kind of a vague periorbital pain, but otherwise healthy. Here's her exam. It's meant to represent normal fundus, but decreased vision in the right eye, this eye. You count fingers, and this eye a little bit down, 20/40. Sluggish pupils on both sides, but a relative atrapupillary defect here with the bad vision. Normal eye movements, discs look like this. Here's her optic nerve. So again, it's a little bit unusual for an MS-related optic neuritis. It's bigger, it's very dense, bright enhancement, and enlarged, and this is the normal optic nerve over on this side. So you're already thinking it's a somewhat older African-American woman, not the 24-year-old white young woman. So this was presumed to be MS-related optic neuritis, actually, and no testing was performed. She was treated with the routine intravenous methylprednisolone, a gram a day for 3 days, tapering oral prednisone, vision improved. She responded to the therapy, came back to 20/50 in the right eye, 20/25 in the left eye. But then as they were tapering, at 6 weeks, the prednisone got down to 10 milligrams a day, and the vision in both eyes went bad again. So this is a steroid-dependent optic nerve inflammatory process where on the tapering, things went bad. This is a repeat MRI at the time when things went bad. So all of a sudden, in addition to intraorbital inflammatory disease, the chiasm, which was actually normal on the previous exam, has this very large, densely enhancing and sort of some fluffy edges here. And on the left side, there are some fluffy edges, infiltration around the center that's relatively spared here. This is a classic appearance of sarcoid, on intracranial sarcoid optic nerve involvement, where you have this sort of thickening of the surround of the nerve, and the nerve in the middle early on is relatively spared, and then later on develops this kind of a picture. She was eventually diagnosed with sarcoidosis by optic nerve biopsy on the no light perception eye. So this is non-infectious, presumably anyway, granulomatous, non-necrotizing inflammation, predilection for the respiratory tract. The optic nerve disease may be the first sign of sarcoidosis. So maybe no other preceding things, no other symptoms. And the onset is slower usually than the typical optic neuritis. You may have retrobulbar optic neuritis, papillitis, infiltrative, and whatever visual field you might have. So you want to think about this if it's an atypical picture, but also if there's uveitis associated, if there are iris nodules, if you see the other things that point you towards sarcoid, like lacrimal gland involvement. But none of them are required. This can be a typical, a usual appearing optic neuritis at the start. So if you've got that appearance, and maybe there are a few features that are saying maybe this isn't MS, look carefully in the periphery for this kind of a thing. So multiple sclerosis periphlebitis, which happens occasionally, looks like this. This is what sarcoidosis periphlebitis looks like. Denser, longer segments, brighter sort of infiltration of those tissues. The disc may look like anything, may look normal, may look diffusely swollen, may have some peripapillary choroidal involvement, may have this big disc swelling and hemorrhage, may have a granuloma on the disc. So sarcoid can look like just about anything there. Atypical appearance within the MRI, as I showed you. And this is diagnosed with ancillary testing. You need real doctors to make this diagnosis, so you have them do the workup. And you've got to really push them, in my experience. If it's only eye disease, especially the people who do this kind of workup don't get very excited about it. They won't do more than a chest X-ray and some chest X-ray and ACE testing, and they'll stop. But you really need either a gallium scan or now the FDG PET CT scan, which will let you know whether other organs are involved here. If you have optic neuritis and it is sarcoid induced, you've got to think about whether this is CNS involvement. You've got to send them for workup. They need a lumbar puncture, just like the syphilis patients. These patients need a lumbar puncture because patients die from central nervous system sarcoidosis. And I've had a couple of patients who presented with optic neuritis, were treated, they responded initially, and then they did not respond. And then more aggressive therapy was done, but we never caught up with it, and they ended up dying from the central nervous system sarcoid. So it's very important to get the neurology team or the rheumatology team involved to aggressively treat these patients.
Excuse me?
Yes?
Can they ever present with macula edema also?
They can. It's not common. Not a common presentation. It's not neuroretinitis. Not a common situation for this. Okay. Last for optic neuritis, neuromyelitis optica. So this is relatively new discussion that we're having with the optic neuritis presentation. So neuromyelitis optica is an immune-modulated neurologic disease that has recurrent inflammatory events, similar to MS. The mechanism is antibody-dependent. This is a different antibody that we think about with MS, but it's a complex mechanism. The target of the autoimmune process in this case may be the astrocytes rather than the other scenario for MS. They get necrotic disease. They get vascular damage in addition to their axonal injury. So it's kind of a worse, poorly responsive disorder. Recovery is less common than MS. And the treatment for neuromyelitis optica involves eventually immunosuppression rather than the immunomodulation that we were talking about for MS-related optic neuritis. This was previously described as a demyelinated syndrome with bilateral simultaneous optic neuritis and transverse myelitis. It was called opticospinal MS in Japan. It was thought of as a variant of multiple sclerosis, but it's not. It's a different disorder. And so that's what we have to sort of revise our thinking about neuromyelitis optica and see how we're going to manage that. So the attention to it started around 2004 and 5 when it was found that most patients with this syndrome have antibodies, the aquaporin 4 IgG antibody to this aquaporin 4 that were specific. The antibodies had pathogenic potential, and these antibodies were quite sensitive and very specific. These numbers have changed over time as the testing has gotten better, but started to link this NMO process to this antibody. The chemical that the antibody is directed against are concentrated in certain areas, and it makes for certain syndromes that we don't usually see in MS, although there's some overlap. So the optic nerves are common. The brainstem is common. Both of those are pretty common in multiple sclerosis as well. But hypothalamus, and particularly this area postrema, this area of the medulla below the pons here, a common area for involvement. And you guys know the area postrema syndrome. Have you heard of this? Not so much. So that's good. Ask your patients who have an acute onset of optic neuritis whether they have had uncontrolled hiccups or uncontrolled nausea and vomiting during the several weeks before they've had this. This is the so-called area postrema syndrome. It's very dramatic in most cases. Doesn't happen with MS, almost never, but it's one of the cardinal features of neuromyelitis optica. So you have to ask about it. They're not going to link that to their optic neuritis issue. So the area postrema syndrome, an important sort of part of this, and you can see it. You can see the brightness here. In 2006, they started to develop diagnostic criteria based on the use of this antibody. So you had to have, at that point, optic neuritis and transverse myelitis, still, both of them together. And you needed 2 of 3 of these supportive diagnoses, so the unusual pattern in the brain, long segments of spinal cord involvement, and a positive aquaporin 4 antibody test. So 2 of those 3 plus that. A lot of things required to make the diagnosis at that point. But in 2007, there started to become attention to the so-called NMO spectrum disorder, which is including optic neuritis, but other of the neurologic abnormalities, but not the whole thing. And for us, that's somebody presenting with optic neuritis and a positive aquaporin 4 antibody test. that showed us that this was among the spectrum of neuromyelitis optica. 2015, these criteria were revised again, and this is kind of what we're using these days to make the diagnosis. And we pretty much talk about it not as NMO now, but as NMO spectrum disorder, because we're often just looking at the optic neuritis that happens with it. So if you have a positive aquaporin 4 antibody and one of the core clinical characteristics, which are, outline that here, optic neuritis, acute myelitis, the area postrema syndrome, and acute brainstem syndrome, or some of the others that are more focused with that, you can make this diagnosis. And it's important to make the diagnosis. I'll tell you why as we go along here. You can also make the diagnosis without having the antibody. You just have to be a lot more rigid in the other clinical and MRI findings that go along with this. I won't go into too much of the detail regarding that. But here's the typical situation for NMO. You got a case. It's an optic neuritis case. It's a 28-year-old woman. She's got a 2-week history of pain with eye movements and central visual loss in the right eye. She's got 2200 vision in the right eye. The left eye at this point is normal. There's a relative afferent pupillary defect on the right, and the right disc has a little bit of swelling. The left disc looks normal and has a dense central scotoma there. So there's your case of optic neuritis. So on the one hand, you're wondering, is this going to be MS? In which case, the vision's probably going to get better no matter what you do. But you need to worry about the risk for future neurologic events. You need to worry about immunomodulation. Or is this going to be a case of neuromyelitis optica, in which case vision's not going to improve unless you treat it, and it might not improve anyway, but you need to treat it aggressively, and that has to occur soon. So how do you distinguish between those two? Well, there's the NMO antibody test. The problem with the NMO antibody test is it takes a few weeks usually to come back. So in the meantime, while you're waiting for that test to come back, you've got to make some decisions about that. Do you do a spinal cord MRI in these cases and try and point you toward neuromyelitis optica? You can, but at least 50% of neuromyelitis optica spectrum disorder begins as just optic neuritis, and the spinal cord is totally normal. So if you find something in the spinal cord, it might help you, even if they don't have symptoms. But the myelitis may come much later, so that may be negative. So here's what you should look at to try and point you in this direction. Look at the demographic features. Look at the associated symptoms, which we mentioned a bit earlier already. The visual field pattern, whether it's one eye or both eyes, how bad it is, and what the imaging looks like. All of these things can help you sort of lean you one way or the other toward NMO. So this is typical NMO, which I showed you earlier today, earlier in the talk here. Older person usually, so the average is about 40 in this scenario. Females are still more common, but this is less common in Caucasian and more common in Latinos and Asian patients. So different demographic. Pain is often less common than in typical MS. It may be sequential. You may start out with both eyes involved at once. The visual loss is usually poor. It doesn't recover spontaneously as much as others. And this picture that I showed you earlier with this greater than half of the intraorbital optic nerve length being involved with enhancement, particularly if it's both sides, and if there's posterior involvement that's headed toward the chiasm here, that's a marker that this may be more likely to be neuromyelitis optica. If you have a patient who presents with optic neuritis, and I told you earlier that multiple sclerosis kind of optic neuritis can produce altitudinal loss, but if you have this kind of bright signal and an altitudinal loss in an optic neuritis case, it's going to point you toward neuromyelitis optica. This is one of the markers that pushes you that direction. If you do the MRI and you see these things that I referred to earlier, unusual for MS, so the area postrema, this region around the hypothalamus, big confluent areas, although this can occur in MS, but this big confluent area, a little bit pointing toward the NMO, and a long segment of spinal cord abnormality leans toward NMO.
Can you go 2 slides back?
2 slides back.
This visual field attitudinal, why it's not multiple sclerosis?
It could be, but when you put all this together, it raises the possibilities that it's going to be neuromyelitis optica, particularly with this kind of a bright signal on the MRI. So this much enlargement and this dense bright would point you more toward NMO than the MS optic neuritis has enhancement, but it's, as I showed you on those first slides, sort of light enhancement. So the combination of this and this is going to lean you that way. It's not 100%, but it points you that direction. So it's a bad disease. Prognosis is bad. They recover poorly. Untreated, at least 50% of them are going to end up with under 2200 vision. There are a number of studies looking at this, and the recurrence rate is higher. They don't recover as well. And if they have spinal cord involvement, they don't recover that as well either. So they end up with atrophic optic nerves and bad vision if you don't treat them. So what do you do for them? If you've got a patient and you think that they're NMO, you can't really wait for the NMO antibody. You're going to consider ordering it, and we'll end with that at the end here. But you've got to think about whether you're going to treat them aggressively. So if there's a question about this, the use of high-dose corticosteroids, you've got to start it, and you need to start it right away. You can't wait for the antibody test to come back. The usual dose is what we start with, 1 gram a day for 3 to 5 days of intravenous methylprednisolone, and then we see what happens. If they don't respond within a few days, and this is variable depending on your institution, but 3 to 5 days typically, maybe earlier if it's severe, they get plasmapheresis and removal of the antibodies that are involved in this. Intravenous immunoglobulin, cyclophosphamide, less good evidence, but Plex, plasmapheresis is step number 2. So it's intravenous steroids and Plex early on. If you don't do that, you risk them not recovering. For attack prevention, after the first attack is over, you've got them controlled. How do you manage neuromyelitis optica? The standard has been azathioprine, and there are very good studies on this looking at the recurrence rates dropping, the annual recurrence rate dropping significantly with azathioprine use. Mycophenolate or Cellcept also is proven to be effective for this. But now, if you have it available, rituximab is probably the most effective medication for preventing further attacks. So many of these patients, if we can get it through the insurance, will use rituximab injections for this. And this also decreases the annual recurrence rate dramatically in these cases. MS therapies, many of them are contraindicated in neuromyelitis optica. Another reason you've got to make the right diagnosis. Interferon B, there are a number of series actually looking at this and indicating that the patients have done worse. They've recovered more poorly, they've had more recurrences with that, and severe exacerbations of the disease with natalizumab or fingolimod. All of these MS drugs contraindicated in neuromyelitis optica. So it comes down to this. Here's the final question about this. Should you order, every case of optic neuritis when it comes in, should you be ordering this NMO antibody? You've got to make a decision early. And here's your case again versus that. So let's go back and look at this. So here's case number 1. It kind of looks like an MS case, right? Decreased acuity, relative afferent defect, normal discs, light enhancement of the optic nerve, abnormal periventricular region, classic visual field loss in this case. Versus case number 2, older Latina woman, bilateral involvement, swollen optic nerve on one side, long segments of enhancement, hypothalamic enhancement as well. So which of those 2 cases do you order the NMO antibody? Does case 2 need NMO antibody testing? That Latina? Do you want to look at the spinal MRI? As Dr. Lee says, that won't be necessary for that case. That case needs an NMO antibody. The question is the other one, that minor one. Should you be doing that? The current standard, although this is evolving, the current standard is if you have things that make you suspicious for NMO, bilateral simultaneous involvement or sequential involvement, severe loss, poor recovery, altitudinal field defect, posterior involvement, long segments of the optic nerve, atypical MRI, then you order it. Because later on, even though you're not going to have it when you start, later on you're going to want to know for sure what you're dealing with, and the antibody can help you in making a definite diagnosis in that scenario. Why do you not do it? So why are you doing it? Number 1, to confirm NMO, avoid missing that opportunity. to distinguish from MS and avoid giving the wrong drugs, which might make things worse. Why not do it? It's expensive. Not that expensive. There's a false positive rate, but it's very low. But the main reason that people don't do it is that it's rare. NMO is not that common. Most cases of optic neuritis are not going to be NMO, and it takes a few weeks to come back. So there's an argument either way. It is starting to evolve toward some of our most prominent neuro-ophthalmologists, at least in the U.S., order NMO on every case of optic neuritis that comes in. Give steroids to every case of optic neuritis that comes in. You can give the steroids, you're probably not going to hurt them. If you miss a case of NMO and don't give them the steroids earlier, you risk the chance of not being able to recover them. So it's leaning toward that way. Still, people are using their clinical judgment to decide whether to order or whether to give steroids initially, but it's starting to go that way, at least in the U.S. Be interested to hear how it is here. Jorn, did you manage this the same way?
Yeah, we did.
So it's evolving, but that's sort of what we do. So for NMO, recognize the atypical parts of it, perform the antibody testing, treat aggressively right away, and avoid the things that are going to cause you problems. So I'll stop there for optic neuritis. Any questions?
I think we'll take it after the coffee break.
After the break.
Yeah,
Everyone wants
people
to stop the
need
break.
time to check out. So it's coffee break after